Hi, my name is Dr. Chelsea Amo-Twiniboa, and I'm a PGY2 resident at the Stony Brook University Hospital in Stony Brook, New York, and a CardioNerds Academy Fellow in the House of Thomas. I'm inviting you to the AHA Scientific Sessions 2024 from November 16th to the 18th in Chicago. There is also an exciting pre-session symposia and early career day on November 15th. It's going to be a celebration of AHA's 100th year with over 500 sessions, including AI-focused content and new 2024 scientific guidelines. The CardioNerds Conference Scholars will be there, so don't miss out. Register today at scientificsessions.org.
And when registering, be sure to use the code NERDS, because if you're among the first 20 to sign up, you'll receive a free 1-year AHA professional membership. And with that, let's get to the show.
Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated CardioNerds everywhere are working hard to fight this global epidemic. These are their stories.
Hi everyone, Dan Ambinder here. On behalf of all of us at CardioNerds, we are thrilled to bring you our Decipher the Guidelines series for the 2022 AHA ACC HFSA Guideline for the Management of Heart Failure. Get ready for short and bite-sized, high-impact clinical vignette-based questions designed to highlight core concepts based on cutting-edge evidence that are relevant to your practice. The cases we use are hypothetical and for educational purposes only. This series was developed by CardioNerds and created in collaboration with the American Heart Association and the Heart Failure Society of America. It was created by 30 trainees spanning college students through advanced fellowship with mentorship from Dr. Lala, Dr. Robert Mentz, and Dr. Nancy Sweitzer. We thank Dr. Judy Bezanson and Dr. Elliott Antman for their guidance. So join us as we get to learn about the guidelines and beyond from 16 leading faculty experts. With that said, it's time to get nerdy.
The following question refers to Section 2.1 and 4.2 of the 2022 AHA ACC HFSA Guidelines for the Management of Heart Failure. The question is asked by CardioNerds Academy Intern Dr. Adriana Mares, answered first by Morehouse School of Medicine Cardiology Fellow and CardioNerds FIT Trialist Dr. Christabel Nyange, and then by expert faculty Dr. Shelley Zieroth. Dr. Zieroth is an advanced heart failure and transplant cardiologist, head of the Medical Heart Failure Program, the Winnipeg Regional Health Authority Cardiac Sciences Program, and an associate professor in the Section of Cardiology at the University of Manitoba. Dr. Zieroth is a past president of the Canadian Heart Failure Society. She is a steering committee member for the Paraglide HF trial and a PI mentor for the CardioNerds Clinical Trial Program. Dr. Zieroth, it's an honor to have you with us.
Well, thank you for having me.
Adriana, do you have a question for us?
Yes, our question is the following. A 50-year-old woman presents to establish care. Her medical history includes COPD, prediabetes, and hypertension. She is being treated with chlorothiazidone, amlodipine, lisinopril, and a tiotropium inhaler. She denies chest pain, dyspnea on exertion, or lower extremity edema. On physical exam, blood pressure is 154/88 millimeters of mercury. Heart rate is 90 beats per minute, and respiration rate is 22 breaths per minute, with an oxygen saturation of 94% breathing ambient room air. BMI is 36 kilograms per meter squared. Jugular venous pulsations is difficult to assess due to her body habitus. Breath sounds are distant with occasional and expiratory wheezing. Heart sounds are distant and extra sounds or murmurs are not detected. Extremities are warm and without peripheral edema. B-type natriuretic peptide level is 28 picograms per milliliters or 28 nanograms per liter. A chest radiograph shows increased radiolucency of the lungs, flattened diaphragms, and a narrow hard shadow consistent with COPD. An electrocardiogram shows evidence of left ventricular hypertrophy. Echocardiogram showed normal LV and RV function with no significant valvular abnormalities. In which stage of heart failure would this patient be classified? A. Stage A, at risk for heart failure. B. Stage B, pre-heart failure. C. Stage C, symptomatic heart failure, or D, Stage D, advanced heart failure? Christabel, based on the patient's profile and test findings, what stage of heart failure would our patient be classified as?
Oh, thank you, Adriana, for this amazing question. I feel like it's important to understand the recent classification for heart failure as per the ACC guideline. So the correct answer for this question is A. This patient is at stage A or at risk for heart failure. So this asymptomatic patient with no evidence of structural heart disease or positive cardiac biomarkers for stretch or injury will be classified as stage A or at risk for heart failure. The ACC-AHA stages of heart failure emphasize development and progression of disease with specific therapeutic interventions at each stage. Advanced stages and disease progression are associated with reduced survival. The stages were revised in this edition of guidelines to emphasize new terminologies of at risk for stage A and pre-heart failure for stage B. At stage A, emphasis is placed on prevention of structural heart disease by aggressive risk factor modification. Healthy lifestyle habits, including regular physical activity, maintaining normal weight, healthy dietary habits, and avoiding smoking, help reduce future risk of heart failure. For patients with established hypertension, coronary artery disease, or diabetes, optimal control of risk factors is crucial. For hypertension, the SPRINT trial and subsequent meta-analysis of 35 BP lowering trials have demonstrated substantial reduction in incidence, heart failure, and mortality with aggressive blood pressure control. For diabetes, as we all know, the SGLT2 inhibitors have demonstrated reductions in heart failure hospitalization regardless of baseline heart failure status. So screening patients at risk for heart failure for disease progression may be beneficial. The STOP-HF study randomized patients with risk factors but without established LV systolic dysfunction or symptomatic heart failure to screening with BNP testing or usual care. Screening with BNP, which is natriuretic peptide followed by echocardiogram and referral to a cardiovascular specialist for those with levels greater than or equal to 50 picogram per milliliter, led to a reduction in the composite endpoint of incident asymptomatic LV dysfunction with or without newly diagnosed heart failure. Accordingly, BNP or NT-proBNP based screening, followed by team-based care, including a cardiovascular specialist, has a Class 2A recommendation in patients at risk of developing heart failure to prevent the development of LV dysfunction or new onset heart failure. So our patient should be counseled with healthy lifestyle, smoking cessation, and weight loss. Her antihypertensive regimen should be intensified for blood pressure optimization. Her ASCVD risk should be calculated and counseling regarding statin use should be provided accordingly. If she develops overt diabetes, she should be started on an SGLT2 inhibitor. Given her BNP level, she does not currently warrant further evaluation with echocardiogram or referral to a specialist. So the main takeaway point for the question is patients with stage A heart failure are those who are at risk for heart failure but are without symptoms, structural heart disease, or biomarkers of stretch or injury. At this stage, the emphasis should be to identify and modify the risk factors. So Dr. Zieroth, would you please tell us a little bit more about the risk factors for heart failure and ways to reduce this risk, as well as the stages of heart failure?
Oh my goodness. Well, I don't have too much to add on top of that wonderful answer. It really is about prevention. We really want to prevent future heart failure cases and the impact on patients. And so it's very important, even at the primary care level in particular. They are the prevention guards of heart failure, as far as I'm concerned. Managing blood pressure adequately, making sure that we are optimizing care of patients with established cardiovascular disease. Lots of interesting CV outcome trials in type 2 diabetic patients in terms of minimizing risk of future hospitalization for heart failure with SGLT2 inhibitors. Obesity, I think we're going to see a lot of interesting data coming out in terms of reductions in heart failure hospitalization with some new agents, minimizing exposure to cardiotoxic agents as well, or making sure that patients are being appropriately monitored. And more we understand about genetic variants for cardiomyopathy, that's stage A population, and those patients with a family history of cardiomyopathy, they're all stage A at risk for heart failure and need to be monitored appropriately. Perhaps the one group that we might have missed off that list when developing the universal definition of heart failure, which then got included in the most recent guidelines, is chronic kidney disease is another interesting group for us to consider. And not just EGFR, but UACR, or urine albumin creatinine ratio, is a marker of both increased risk of cardiovascular death, but also hospitalization for heart failure. And we're seeing some other guidelines recommend routine screening of EGFR and UACR for this very reason, including some of the preventative cardiology societies in the US, and the Canadian Cardiovascular Society as well just recommended routine screening in patients to assess these additional risks associated with CKD.
What a great discussion, Dr. Zieroth. I learned the importance of prevention in patients with heart failure, including blood pressure management and routine screening for chronic kidney disease. Thank you so much for your time and the knowledge you shared with us today.
It's a pleasure to be here today.